back to the point that we were discussing earlier of community programs versus professional programs, and even more, it pertains to the whole issue in American healthcare of acute episodic care versus chronic care, preventative care. And so diabetes teaches us that the goal is all about lifestyle and all, in conjunction with appropriate medical therapies.
But I want to get back to the community because, again, we know when we talk about diabetes, there are health disparities, and so access to care is an issue. I know Michael and I are both from states that have very rural populations, and so although there may be in a metropolitan centers of excellence or endocrinologists, in some of the rural communities there are not. And so in the managed care world, we can leverage telemedicine, we can leverage a lot of the community advocacies through our advocacy program.
And diabetes is a disease that's really overrepresented in socioeconomically disadvantaged groups. So I'm in New York City. There are a lot of pockets of extreme socioeconomic disadvantage, which are tremendously overrepresented in diabetes, and even more in diabetes complications, in amputations and in development of end-stage renal disease and cardiovascular outcomes. So this is, I think, generally applicable across the country in all sorts of areas, and we don't know yet, and managed care hopefully can help us learn how to reach these populations.
Definitely we see that access is really a big contributor to why the management of the condition has been such a challenge across the United States.
Well, also on two levels, you need to, on the community level, you need to go to where the people are. And that means having trained community volunteers who can reach out to people, in their community centers, in their churches, those sorts of places, and provide basic lifestyle and encouragement, support. At the other end, in, as you pointed out, the primary care office, where you can't have a dedicated, I have two dedicated diabetes educators. You can't have that in a primary care office, but what you certainly can have, and what we try to encourage in some of our rural practices, is a diabetes champion. You might have a nurse, or you might have an MA who has a particular interest in diabetes, who can go to a slightly higher level of understanding and then help you to facilitate within your practice the care of those patients, reaching out to them, re-engaging them, reminding them.
But this is also where the managed care community can help, because a lot of the managed care payers have disease management programs, such as like WellCare. We have a diabetes management program where we have the personal health coach, the community health worker that does exactly what Michael just referenced.
How does that integrate or coordinate, sort of in a seamless fashion? Is that telephonic service? Is that a?
So it's the disease management is telephonic, but if the member transitions into case management, in some cases that's field-based. And we take direct referrals from the provider community, whether the specialist or PCP. We surveillance our historical claims data or HRA health risk assessment data for members that join the plan, and we find out that they do have diabetes and they're not connected to care. We want to make sure they have a home, a medical home. They're connected to a doc that we can partner with. And then how do we wrap them around these services for weight management, nutrition, counseling? And I think what we're seeing a lot is the referrals from the PCPs are just not there. Again, we'd like to have physicians refer more of their patients to the managed care community in a collaborative way. Again, our role is to be more supportive, not intrusive. And so we're just seeing a lot of these programs somewhat underutilized.
So here's diabetes. 1 out of every 10 adults in America has diabetes. And in a physician's practice, I don't care where it is, whether it's in rural Alabama or in the inner city New York, it's going to be way more than 1 out of 10. So this is highly prevalent. These are people who are sick. They're the ones who incur much greater healthcare costs, who incur much greater personal costs and illness and all the adverse outcome of diabetes. And so we have to learn how to take the resources that you're offering, use the resources of a nurse champion in a physician's office, and then really make it work to help people.
One program we did, because I think you're absolutely right. You know, we Jocelyn has a program where we take our educators and train primary care practice medical assistants typically on some of the basics around diabetes and create that local champion. And it's been super effective because again, there are not enough, just like there are not enough endocrinologists, there are not enough diabetes educators either. And so leveraging that knowledge more broadly by training individuals and then guiding them along the way, I think is really the long-term answer.
And I think the final point I want to make back to the PCMH is the managed care community can incentivize providers to participate and obtain that type of certification such that the reimbursement offsets the cost, the startup costs. There are various ways it can be done, an enhanced fee schedule, care coordination. At the end of a quarter, you can do a shared risk agreement and spread the cost from a cost avoidance model. So there are ways we can incentivize providers and make it more attractive for them to want to become a PCMH.
Right, so
And I think broadly that's been helpful. I mean, if you know, the programs that haven't done two things. One, provide some extra resources for the practice, but the second piece is someone to guide them on how to change.
Absolutely.
Because it's changing their model and they may not be able to figure it out because they're trying to do this while they're seeing, you know, 20, 30 patients a day.
And for the managed care community, it's okay to do that
Yeah.
because with the additional cost,
There'll be
downstream
savings.
it's cost avoidance
Right.
from readmissions and
Absolutely.
ER
So,
utilization.
I just wanted to say that so often it's perceived, not entirely incorrectly, as an adversarial relationship. We need prior approval for this and this and this and this, and it's a huge burden for physicians actually caring for human beings with illness. So I applaud what you're saying, and I only hope that this is something that can be translated so that physicians don't see the managed care companies as their adversaries and begin to see it as a beneficial partner. But
So it
it will
takes,
require work on everyone's part.